So femur comes from the Latin os femoris, which means thigh bone, and it's the longest, strongest and heaviest bone in our body, accounting for about a quarter of your height, and it's stronger than concrete. It functions to transmit the weight from your hip bone to your tibia, and it also provides anchor points for over a dozen different muscles, allowing us to move our lower limbs. So superiorly it articulates with a part of your hip bone called the acetabulum to form the hip joint, and inferiorly it articulates with the patella to form the patellofemoral joint and the tibia to form the tibiofemoral joint, or what we would collectively call the knee joint. Anatomically, the femur is divided into three regions, and we're going to discuss these in turn in this tutorial. So the proximal femur, the shaft, and then the distal femur. And then we're going to finish this tutorial by looking at a couple of different angles, the angle of inclination and the torsion angle of the femur, which you might come across. So firstly, before that, particularly if you do cadaveric anatomy, you'll want to know how to orientate yourself to a femur, so which side it is. This is really easy to do, and all you do is you look at this line here, which is on the back of the femur, and that's called the linea aspera. If you then obviously rotate the femur round, you can tell which side it is. So if the linea aspera is on the back, this femur will be a right-sided femur, because the head of the femur obviously always points towards the joint. So let's just now look at some of the proximal features of the femur. So the first thing to notice is the head of the femur, and then next to it we then have the neck of the femur. So just to give a little bit more to this, the only important point of the head of the femur is the fovea capitis. Now that's this central depression that you can see in the center of this femur. Now this has an important role in blood supply in childhood. So when you were a child, the head and the neck of the femur are separated by the cartilage of the epiphyseal line, which is your growth plate. So you need two blood supplies. You need one that goes to the neck of the femur, and you need another that goes to the head of the femur, because the cartilage in the middle is, as all cartilage is avascular, so it doesn't have blood vessels running through it. So we have arteries that supply the head of the femur come through the ligamentum teres via a branch of the obturator artery, and the neck of the femur is supplied by the circumflex arteries that come off the femoral artery. When you reach adulthood and obviously your growth plates fuse together and there's no more cartilage there, the artery that comes through the ligamentum teres actually obliterates, and now in adulthood all of your blood supply that goes to the neck and the head of the femur is supplied by the circumflex arteries that wrap around the base of the neck, and that has some important clinical consequences if you were to have a fractured neck of femur. The next thing to notice are these two bumps here, which is the greater and lesser trochanter. And then between these two, you have effectively two lines. So on the front, it's called the intratrochanteric line. And then on the back, confusingly, it's then called the intratrochanteric crest, because it looks more like a crest than a line. And finally, the only other thing which isn't really shown very well at all on this model is the quadrate tubercle. So 2/3 of the way up the trochanteric crest, there is this small bump, and that's for the quadratus femoris, which is just a small lateral rotator of your hip. So that's the only real things that you want to notice on the proximal aspect of the femur. So now let's take a look at the shaft of the femur, and the first thing to notice is the slight medial direction of the femoral shaft. Now basically the femoral shaft moves towards the knee because it helps to bring your lower limb closer to the center of your body, and that helps to improve your stability. And there are a few structures to recognize on the shaft of the femur, but they're quite easy to remember because they're sort of linked together and you go from the top to the bottom. So the first thing to notice here is the pectineal line, and that's for the pectineus muscle. The next thing next to that is the gluteal tuberosity, and that's the attachment point for the gluteus maximus muscle. So these two bits converge to form the linea aspera, which we saw earlier on, which is that ridge that runs down the posterior aspect of the femur, and it's the attachment site, or one of the attachment sites, for the hamstring muscles. And then if we move distally on the shaft, the linea aspera actually widens out to form the floor of the popliteal fossa, which is where a small muscle called popliteus lives, and that muscle's heavily involved in the locking and unlocking mechanism of your knee. So finally, the linea aspera widens out to form these two ridges called the medial and lateral supracondylar ridges. And the medial one stops at this bump, which is called the adductor tubercle, and that's where the muscle adductor magnus attaches. And so finally for this part, let's just go through the distal femoral features. So firstly, you have two condyles, and condyle just means knuckle, and you have a lateral one and a medial one, and they're covered in hyaline cartilage and sit on the top of your tibia to form the tibiofemoral joint. And then slightly above these are two smaller knuckles, which are called the medial and lateral epicondyles. And so, also on the anterior aspect of the knee, we also have a groove which the patella runs in, which is called the trochlear groove. However, it's been assigned various names, including the trochlear notch, patella groove, and the femoral sulcus, but just remember they all mean the same thing. However, primarily it's mostly referred to now as the trochlear groove. And finally, if you look on the posterior view on the right, there is an intercondylar fossa, which is a depression between the two femoral condyles, and that provides the attachment points for the anterior and posterior cruciate ligaments. And the final things that I just want to touch on for completeness are two angles that the femur naturally has: the angle of inclination and the torsion angle of the femur. So the first thing is the femoral angle of inclination. So all this is the angle that's formed between the intersection of a line an imaginary line that's going down the shaft of the femur and a line that's going through the neck of the femur. And so typically in the normal adult, we have an angle of inclination of between 120 and 135 degrees. But please bear in mind that, as with all the angles that I'll say, that different texts will state just slightly different figures. But the average healthy adult has an angle of inclination reported to be around 130 degrees. But if this angle increases more than 135 degrees, then it's referred to as coxa valga. And if this angle decreases less than 120 degrees, then it's referred to as coxa vera. And finally is the femoral angle of torsion. So it depends what book you're reading, because it's got a couple of different names, including the femoral angle of torsion, femoral neck anteversion, and also the angle of declination. So I've put three different images on the screen because it can be a bit confusing to describe, and I think it will help hopefully with some of the conceptualization when I'm describing it. So basically, the angle of torsion is formed by looking at the relationship between the axis of the femoral head and neck and the femoral condyles. So if you just take a look at the top right picture, you have to imagine as though the femur is lying flat on a table, and you take a line on the base of the table. So imagine where the table is, that's a line that's running on the base, and then you take another line that runs through the head and neck of femur, and where those two lines intersect, you will get an angle. So the middle picture is looking down, so top down on the femur, and it's just easier to see what we're referring to. So The normal femur has an angle of torsion of between 10 and 15 degrees antiversion. So antiversion just means leaning forwards, and in this context it means the femoral neck is leaning forwards in the normal person between 10 and 15 degrees. If this angle increases, so i.e. 20, 25, 30 degrees, that's obviously an increase in femoral antiversion, and if the angle decreases, then that's referred to as retroversion. And really, it's only really important to note that these angles are completely normal aspects of the femur, but if they become grossly abnormal, they can affect joint stability. And an example of this is femoral antiversion, which has an occurrence of stated up to about 10% in children. So it's worth noting when you're born, you have a degree of antiversion, so your neck of femur lies forward by 40 degrees in respect to your femoral condyles, and as you get to adulthood, that actually reduces down to between that normal 10 and 15 degree rate. If you have a very large angle of antiversion, though, that can be responsible for an in-toeing gait pattern in children, which is just where. So firstly, the tibia and the fibula form the leg, and remember that we're referring to this in an anatomical sense, where the leg refers to that which is from the knee and below. The tibia, which is commonly referred to as the shin bone, is the second strongest bone in the human body, and it carries all of our weight down through and into the foot. Whereas the fibula, which is Latin for pin or clasp, provides much more of a supportive role, so it has a very insignificant role in weight bearing, and in literature this is stated to be less than 10%. So this has some clinical consequences which are important, and just to note that the fibula provides a great site for bone grafting, because if you remove a bit of the fibula out, then it's not really going to impact on the stability of the lower leg. And secondly, if you have a fracture of the fibula, and this is specific really to those which are in the proximal aspect of the bone and those which aren't really largely displaced, you can actually allow the patient to mobilize as the pain allows without any cast immobilization. However, the majority of the fibula's role is actually in providing support, particularly lateral support to the ankle, where it has an extremely important role. So now let's think about the articulations that these bones have. So exclusive to the tibia at the top is the tibiofemoral joint, which is part of that knee joint. And then between the tibia and the fibula, we have the superior and inferior tibiofibular joints, and then distally on the fibula and the tibia, they also form joints either side with the talus to form the talar crural joint, or what we commonly known as the ankle joint. So now let's think about orientating ourselves to these bones. So firstly, let's just take the tibia. So the tibia is quite easy to orientate yourself to. So to find the front of the tibia, so the anterior aspect of the tibia, you find the bump which is at the top. This bump's called the tibial tuberosity, which is here. And so if you find that, then you know that's the front. And then if you find the base of it, you should find there's a lump at the bottom, which is called the medial malleolus. And this faces obviously towards the midline. So in this particular example, this is a right-sided tibia. So the fibula is much harder to orientate yourself to, and the only real way to properly do this is actually to get the bone itself and feel both ends, or tap both ends. One end will feel flatter, and that's the head, and one end will feel much more pointy, and that's the lateral malleolus. Once you've found the lateral malleolus, then you know that that's the distal part of the fibula, And then what you've got to do is find which way around it is. And what you do to find that is to look for this part here, which is that concave section on the inner aspect of the fibula, which is the lateral malleolar fossa. And this bit just joins onto your talus. So once you find that concave bit, you know that that's the inside bit, and you've effectively got your laterality to that bone, so you've been able to orientate yourself. And in this case, this is a right-sided fibula. So now we're just going to go through the bones themselves, and we're going to start with the tibia, and we're going to go top to bottom, okay? So thinking about the proximal structures on the tibia, so firstly you've got these two large bumps. You've got a medial and lateral condyle, which are these shelf-like projections, and on the top it's quite flat, and this is called the tibial plateau on the top, and you've got a medial and lateral section to that. And those condyles obviously house the femoral condyles. Now, the tibial plateau, the medial and lateral tibial plateau, join in the middle to form the intercondylar eminence, which is this raised bit in the middle, this lip in the middle of the tibia. And the intercondylar eminence is important because it allows the attachment of three structures anteriorly on it and three structures posteriorly. So just taking this view, so a top-down view, effectively bird's eye view, so looking at the intercondylar eminence, on the anterior section of it, most anteriorly we'll have the anterior horn of the medial meniscus. Then just behind that you have your anterior cruciate ligament, and then behind that you have your anterior horn of the lateral meniscus. And then looking at the posterior part of the intercondylar eminence, at the front of that bit you've got the posterior horn of the lateral meniscus, and then you have the posterior horn of the medial meniscus, and then most posteriorly you've got your posterior cruciate ligament. And so to summarize that, kind of essentially the intercondylar eminence just allows us to attach our menisci and our cruciate ligaments. And so finally, the last thing to notice on the proximal aspect of the tibia is this bump which we visited on the front of the bone, which is called the tibial tuberosity. So this provides the attachment point for the quadriceps via the patellar tendon. And just as a clinical aside, the tibial tuberosity can be an important landmark for children presenting with knee pain. So there is a growth plate that develops underneath the tibial tuberosity at 4 to 6 months postnatally, and this fuses at 16 years old. And particularly in kids that play a lot of sports, you can effectively get an overuse injury here, where the quadricep muscle bulk and strength actually overdevelops itself, and so it's pulling against this relatively weak growth plate, and over time that repetitive strain of the tibial tuberosity can cause very small avulsion fractures, which means it's pulling the bone away. And as these repair, the tibial tuberosity grows, so it's enlarged and it's painful. It's known as a traction apophysitis, which goes by the name of Osgood-Schlatter's disease. And this tends to run a course in which it sort of burns out as you become an adult. So next, let's just think about the shaft of the tibia. Now, the tibia is effectively a triangle in shape on its shaft. So there's 3 borders and there's 3 surfaces. So firstly, just to go through the borders, there's an anterior border, a medial border, and an interosseous border. And then to go through the surfaces, We then have a medial surface, which is the smooth, flat part, which is often called the shin, and that's very subcutaneous. You can feel that very easily, and that runs from the medial condyle of the tibia right down to that inner aspect of your ankle. We also have a lateral surface, which is ever so slightly concave, and that houses the tibialis anterior. And we have a posterior surface. And on the posterior surface, the most important thing really to note on here is this ridge, and that's called the soleal line, and that houses the soleus muscle. So now just looking at the distal aspect, so effectively the shaft itself tapers so it gets smaller for 2/3 of its length, and then it broadens in the last third, creating the medial malleolus, which is the most distal point, and that forms the inner portion of the ankle. And so just to add a little bit more to this, the tibia is the commonest fractured long bone in our body. And the fractures that occur in it tend to be between the junction that is from the upper 2/3 and the lower third of the bone, because in that region you have a much poorer blood supply. And particularly the proximity of that medial surface to the skin also means that it's a very high risk to be a compound fracture, where there's a break in the skin around the broken bone. And therefore, because of that, it's actually even more likely to get infected as well. So now let's just think about the fibula. So at the superior portion of the fibula we have the head, and that has a medial facet for articulation with the lateral condyle of the tibia. And the head also provides attachment to the biceps femoris muscle, which is one of your hamstring muscles that bends the knee. And finally, the head also allows attachment of the lateral collateral ligament, which is one of the ligaments that stabilizes the lateral aspect of your knee. And then just below the head is the neck of the fibula, and that's particularly important because it provides a channel around which the common peroneal nerve runs. And clinically, that's important because if you fracture the head or the neck of the fibula, there's a risk that you'll damage this nerve, and clinically, you'll see a patient with a foot drop, which is where they can no longer dorsiflex their foot, and they present with their foot in this position. Then the fibula, similarly to the tibia, has 3 borders on the shaft. It has an anterior border, an interosseous border, and a posterior border. And distally it forms this bump here, which is the lateral malleolus. Now that's lower than the tibial's medial malleolus, and that allows actually a little bit more stability to be provided to that lateral part of the ankle. And that's very important because the lateral part of our ankle is very easily injured, and that's commonly seen in the mechanism of injury is almost exclusively an injury
on the bones of the foot. So in the foot you've got
tarsals, metatarsals and phalanges. So I'll just remove the tibia and the fibula so we can take a look at the tarsal bones first. So you've got 7 tarsal bones. So these are the bones that come before the metatarsals and the phalanges, and you can separate the tarsal bones into a proximal and distal group. So in the proximal group you've got 2 bones. You've just got this bone here which articulates with the tibia and the fibula, so it's this bone here. It's called the talus, and you've got the calcaneus. So those are the 2 bones in the proximal row. The distal row, you've got 4 bones. So the distal row are the bones of the foot which articulate with the metatarsals. So you've got the cuneiform bones, which are these 3 bones here. So you've got a medial, an intermediate and a lateral cuneiform bone, which articulate with the first to third metatarsals. And then you've got this bone here, which is the cuboid bone, sitting laterally, and this articulates with the lateral two metatarsals. And then you've got an intermediate bone. So this is a bone which sits between the proximal and the distal rows. So this bone is called the navicular. So I always used to get confused when I was learning about this, because I thought by looking at this lateral view, you can see that the cuboid bone is kind of in line with the navicular bone, yet the cuboid bone is in the distal group. So the distal group of tarsal bones are just those bones which articulate with the metatarsals. So the intermediate bone, this navicular bone, sits between the proximal row and the distal row of tarsal bones. So just looking back at the proximal bones, you've got the calcaneus, which articulates above with the talus, and anteriorly it articulates with the cuboid bone, and the talus bone articulates below with the calcaneus, and anteriorly it articulates with the navicular, the intermediate bone. So looking at the navicular, you can see it's anteriorly it articulates with the cuneiform bones, so the medial, intermediate and lateral cuneiform bones, and the cuboid bone in the distal row of tarsal bones articulates anteriorly with the lateral two metatarsals, and the cuneiform bones articulate anteriorly with the medial three metatarsal bones. So those are the 7 tarsal bones. So you've got a proximal row with the 2 large bones, the talus and the calcaneus, and you've got a distal row which contains the cuneiform bones, the 3 cuneiform bones, and laterally you've got the cuboid bone, and then you've got an intermediate bone called the navicular, which sits in between the proximal and the distal row of tarsals. So anterior or distal to the distal tarsal bones, you've got the 5 metatarsals. So you've got a base, a shaft and a head to each metatarsal, and then even more distally you've got the phalanges. So the phalanges consist of 3 bones, so you've got a proximal, a middle and a distal phalanx, except for the great toe, which just has a proximal and distal phalanx.